had the first we had the first CME 3 months back on corneal topography by Rajat Jain. It was a wonderful CME. And then we had planned that every month we shall have one CME on some basic topic that would be very beneficial for all of us, especially the residents. And I would request all the residents to join as much as possible in all these types of CME so that they have a good basic knowledge of the basic in ophthalmology. It's always important to see that we work on the basic principles rather than just going on a very, very high by things and not remain on the ground. So I thank Dr. Malay first, who is the president of UP State Ophthalmic Society, to start with this new initiative. And I thank Dr. Abhijat Chaturvedi, who is a very good retina specialist at Kanpur. Dr. Abhijat, welcome to this new UPSOS initiative. And I am sure we all will love to hear from you regarding OCT. See, we all are doing OCT, but I think there are small things which I think most of us miss. And this is the most important thing for this CME to know what we don't know. And I have seen Dr. Abhijat when he was faculty here at Netrojit ICT for the PG teaching program at also at Lucknow at SGPGI. We had the last year PG teaching program. He was so much passionate for teaching. I liked his attitude so much that really we are thankful, Dr. Abhijat, that you are with us. And I think we can start with your presentations. Thank you, Dr. Abhijat.
Thank you so much, sir, for the kind introduction. And yes, definitely OCT is something which is actually an art form. Just to read an OCT, it gives you loads and loads of information about the disease process that's happening. So before I begin my presentation on OCT, so this presentation would basically be just a second. I'll just set this so that it doesn't disturb us. Yeah, perfect. So before going into the details of OCT, I would like to tell you that while reading or before reading an OCT, you should always stick to your basics. And if you do that, 10 out of 10 times you will be able to read an OCT. It's definitely slightly confusing if you don't know the basics. So that's what I'm going to focus on the today's topic. So I think my slides are getting displayed, right?
Yes.
Okay. So as we all know, there are three types of OCT. Why do we need to know that there are three types of OCT? आजकल के ज़माने में you just need to know that spectral domain is the most common one which we use. But no, we definitely need to know what was in the past, what is today, and what is going to happen in future, because the technology keeps on evolving continuously. So initially there was time domain OCT, which had just 400 A scans per second, which is very less, and it gave a resolution of around 10 to 15 microns. So you can see that the images, the layers that are displayed here, according to the pre-scan images, they are not very distinctive and not very clear. But yes, you can get a gross idea of what's happening. After that came on the spectral domain OCT, which was a game changer in the field of OCTs. This gave a scan speed of 20,000 to 40,000 scans per second, which is quite a lot. And the resolution was enhanced to up to 5 to 7 microns. And now you can see very clearly that every layer is defined, and you can catch a very brief or a very short or a very early stage disease from this scan. Now, so as you all know, humans are never satisfied. So we jumped on to swept source OCTs. These gave roughly around 1 lakh to 4 lakh A scans per second with a very beautiful resolution of around 4 to 5 microns. So now not only your retina, but your vitreous cavity, your entire choroid, including all the layers, and even beyond that, you can observe the sclera also on the swept source OCT. The only issue is its cost. It's very expensive. So it doesn't come under 1 CR, it comes above that only. So now how do you want to tackle this problem? So you just add a technology which is basically a ZEISS technology, and it's known as enhanced depth of imaging, or EDI. What does this EDI mean actually? So in EDI, there's a zero delay line, and we set this zero delay line beyond this sclerocoroidal junction. So when you do that, a spectral domain OCT can almost give you an image equivalent to UPSOS OCT. The difference is you won't be able to get such a wide field, but yes, the enhanced depth is definitely there. Another important point in this slide, which I personally prefer, that I prefer the grayscale images rather than the colored ones. The grayscale images are always preferable. I've seen in many institutes, people are still following these colored images. So you can miss very minuscule, pathologies in a colored image, which is hard to miss on these grayscale images. Now this, as we all know, we have been studying this retinal anatomy from, I don't know, my MBBS days maybe. And all our professors always, used to focus that you need to know this. You need to just cram it up and you need to know it. I beg to differ that you don't need to cram it up. You need to understand why all these layers are where they're supposed to be. All of them are connected. It is a fine network, of neurons, and they are membranes. These membranes, however, are not true membranes. So now, in my coming subsequent 2 to 3 slides, please focus on these membranes and their areas where I emphasize, because this is the part where people get confused while reading an OCT. So firstly, you need to remember this external limiting membrane, this blue line. Where is it? It is in the photoreceptors, but there's an inner part of the photoreceptor, which is the nuclear component, and there's an outer part of that same photoreceptor complex. So remember this blue line, external limiting membrane, as your first line. After this comes the ellipsoid zone. So the outer part would be divided again into two parts, which I will discuss in the coming slide as well. This is the second line, which is the ellipsoid zone. So your first line is the external limiting membrane. The second line is the ellipsoid zone. Your third line is the RPE-Brooks complex. Now this green line, many of us would be knowing about this, but most would not, because this green line is the middle limiting membrane, which is duly recognized by the American Academy, but not much in the rest of the world. Now, why is it important to know this middle limiting membrane? It lies between the inner nuclear and outer plexiform layer. About that, I will come in my subsequent slides. Now, when we expand the anatomical diagram of this photoreceptor, as I said, there is one nuclear part, then there is one line, which is the external limiting membrane. After that comes the outer part of the photoreceptors. This part is again divided into the inner segment and the outer segment, or IS and OS. And the junction is ISOS, or the ellipsoid zone. So when you see the entire part, what is happening in the OCT? This is the outer plexiform layer, the outer nuclear layer. See, you can see this entire part is the photoreceptor. Okay, this is the outer plexiform layer, the outer nuclear layer. Then comes this black line, or the external limiting membrane. Then comes the outer part of this photoreceptor, which is divided in the inner segment and the outer segment. And this is the ISOS junction, where the cilium is marked. So again, I'll go back for one slide. So this is the blue line, which is the external limiting membrane. This was the outer nuclear part, external limiting membrane. Now the outer part of this nuclear complex, which has inner segment, outer segment, and dividing this is the ISOS, or the ellipsoid zone. So once this anatomy is clear to you, you can very well go ahead and try to correlate in the OCT. Now the layers have been divided based on the reflectivities. The first is the nerve fiber layer, which is one of the innermost layers, and it is a very broad layer. It is one of the most high reflective layers. Now remember that anatomy of the three lines which I told you before, and start correlating that lines. The first line is the external limiting membrane. Okay. Now, according to that anatomy, after external limiting membrane should come the inner segment of the outer complex of photoreceptor, which is this hyporeflective space. After this would come the ISOS junction. So this is the ELM. I request everyone to kindly mute their microphones so that others can hear properly. So this is the external limiting membrane. Then comes the outer segment of the photoreceptors. Then comes the, ISOS junction. And after that, again a small gap. And after that should come the RPE Brooks complex. So these three layers are very important, and people definitely majority of the time gets confused which is the ellipsoid zone, which is the ISOS junction. So if you remember that anatomy very well, which states that there is one external limiting membrane after which starts the outer component of the entire photoreceptor complex. That complex can divided into an inner segment and an outer segment, which is divided by this line which is known as ellipsoid zone. Because previously the difference between IS and OS is not very significant on OCT, therefore a broad area known as ellipsoid zone was defined. And this is very important to know because ellipsoid zone, when defective, it doesn't get healed. And you need to catch that on OCT. Now, next comes layers with the moderate reflectivity, which include our plexiform layers. So you can see they are not as reflective as the previous layers which I mentioned, but yes, they are hyper reflective, but at a moderate level. And the low reflective layers are the nuclear and the photoreceptor layers. Another very important thing, why we used to be told that there is the plexiform layer, outer plexiform layer has two components, one dendritic and one axonal. Why do you know this? Why is it important? Because you need to know the arrangement. Again, remember anatomy always. If you remember your anatomy, you can never, make a very gross mistake. So this dendritic part of the outer plexiform layer is arranged in a perpendicular fashion. But as soon as you reach this perifoveal zone, it suddenly takes a radial turn, not a perpendicular pattern. Now, again, why do you need to know this? Because when you see something like this, it happens in that particular part. So this is a outer Henle hemorrhagic maculopathy. This is not seen very commonly, but yes, I have personally seen a case in my fellowship days. And then at that time, I learned the importance to know the anatomical arrangement of these fibers. So whenever you see such a star-shaped hemorrhagic pathology going near the perifoveal area, always go for an OCT. And on OCT, you can see such an appearance that is happening in that axonal part of the outer plexiform layers. And this is known as OHHM or outer Henle hemorrhagic maculopathy. Now, when you combine all of this knowledge, till now what you have perceived, you get an entire OCT. And this is the entire OCT, which is, very easy to read now. Always begin from one side. Either go from outside to inside or inside to outside. What I do, I go from inside to outside. So you can see a posterior vitreous cavity area also. Then you can see this attachment of the vitreous, of the cortical vitreous. Now you can see all the hyperreflective, the hyporeflective, the moderately reflective or the lower reflective layers also. And finally those three lines, which are very important. The external limiting membrane, after which comes the inner segment part, the ellipsoid zone, after which a small hyporeflective part, which is the outer segment part, and finally the RP Brooks complex. This is the part where retina gets over. After this comes the choroid. The choroid has, as you all know, choriocapillaries, the saccular halar layer, and then the sclerochoroidal junction. So this you should know. If you don't know this, you will never be able to diagnose anything on OCT. Always diagnosing on OCT is something which should not be done alone. You should always correlate it with the history taking. Your clinical examination, it holds utmost importance. Then the imaging, and then you do an OCT and correlate everything and reach a diagnosis. Never be in a rush to that you'll just have a look at the OCT and make a diagnosis. Never do that.
Abhijat, before we proceed further, we can just have once more the layers in the last slide for the residents, so that they have. Can you go one by one again for the help of the residents, so that we can go from Brooks membrane towards the upper side?
Okay, so what I follow that I start from the inner part
Okay, we
to
can
the
start
outer
from
part.
there also.
Yeah, uh, because while reading an OCT, we generally do that. So I follow that. So that's why I prefer that. So, like I
Okay.
mentioned, a layer with hyperreflectivity, and the hyperreflective layer includes 4 lines. First is the nerve fiber layer. After that would come these 3 important parts, which is the external limiting membrane. So if you remember that anatomical diagram, after external limiting membrane should come the inner segment part, which is this hyperreflective layer after the external limiting membrane. After that would come the EZ, or the inner segment, the outer segment junction, ellipsoid zone, or the ISOS junction. And after this would come our RP Brooks complex. So these are the layers with high reflectivity. After the layers of high reflectivity have been done, we look at the layers with moderate reflectivity, which includes our plexiform layers. And after the plexiform layers are over, we come to low reflectivity, which includes the photoreceptors. Okay. And when you combine all of this, you get an entire OCT, which can be read easily. So, while taking an OCT, what you need to keep in mind. So this is something which happens very commonly in myopic patients, especially because of the longer axial length. The zero delay line, which I mentioned earlier, before you take an OCT, always remember that you do not cross the zero delay line, because after this, the entire image gets reversed. You start getting a mirror image. And once you get this mirror image, it means that yes, you have crossed this line and the image has inverted. So this might give you a false diagnosis of like maybe retinal detachment, which is actually not there. It's just that you have crossed that zero delay line and the image has started getting inverted. So this is called as mirror artifact. After the mirror artifact, you can see that there is some vignetting in this image. Vignetting means basically shadowing. So while recording an OCT image, there should be no shadowing. So people generally nowadays with the advanced machines, we many times take a scan in the undilated pupils, but you can very well get vignetting in the undilated stage, so it's never advisable to do that. Now, this image is again not a very good image because it has an out of range error. So this part of the scan is all right because you can see all the layers, including the choroid. However, when you reach here, the RP Brooks complex, and beyond that, when you go into the choroid and the sclera, you cannot see. So this is out of range. So if there's some pathology here, you won't be able to record it. So avoid this. Now, there are commonly encountered OCTs, which I'll be discussing and I'll be showing you. And the things which I have parted with you till now, try to combine them and try to find the things before I tell you. And I'm very sure if you combine your basic knowledge, you will definitely be able to catch the details here. The first is a common thing which we encounter in our OPDs is the vitreomacular traction. So as the name suggests, what is it? The posterior cortical part of vitreous gets attached at the macula and it starts pulling it. There's a traction there. If there wasn't a traction and there was only attachment, it would have been a vitreomacular adhesion. So how does it look on an OCT? So now there are two OCTs. The above image shows a milder form of traction, while the below image shows a very severe form of vitreomacular traction. Now, what would I like to show you here, guys, is that what is this? This is not cystic edema. This is not intraretinal fluid. People many a times call this intraretinal fluid and they advise the patient to go for an injection straight away. However, if you observe these lines over here, there are striations in between the layers, which are suggestive of the fact that something is getting pulled. There is traction. And because of this traction, stretching, there's a sciatic-like thing happening over here. Always look for these lines or these striations. If they are there, it's not a cystic edema. Cystic means cyst. Cyst is a circular thing. This is not a circular thing. This is not fluid inside. Rather, this is a schisis. And a very bad thing also which happens with this very bad VNPs is something which is developing here. You can see all the layers are coming totally fine over here, but after this it gets abrupted. The entire thing is pulled. This is an outer retinal defect, the defect in the outer layers. If this traction is not resolved, ultimately what will happen, this will convert into a macular hole. So when I'll come to the macular hole slide, I'll show you how this actually gets converted. So people give injections for that. And I don't deny giving injections for this condition, but the reason for giving an injection is different. It's not for the anti-VEGF purpose. You all must be knowing that after giving anti-VEGF injection or other any intravitreal injection, many a times PVD is induced, posterior vitreous detachment is induced. And if that detachment happens, this traction will go away. If that goes away, in time it settles down. Similarly, in this image, this is a pseudocystic space, not a true cyst. So that's why I say always correlated clinically, don't make a diagnosis only on OCT. And while reading an OCT, see everything very carefully. Okay. Then again, another common thing which is very important for all of us is diabetic retinopathy, which we see very commonly in our clinics. This is a case showing somewhat moderate to severe NPDR, and we want to when we went to quantify that CSME component, you can see in this image, there is some intraretinal fluid or cystic edema happening, some exudates there. Okay, and now you can appreciate this ellipsoid zone line, which is coming, and vanished. Now it's not there, it's very irregular. Okay. Now, why I have put this slide, try to focus on that important part. This is another patient having somewhat similar picture as to this one. Now comes the importance of OCT. So when I went to do an OCT and I tried to quantify that CSME, you can see the marked difference in the two conditions. This CSME is not same as CSME. This is very worse. It even has a subretinal fluid or a component of neurosensory detachment. So this is definitely a worse condition. This might get resolved with one single injection, but this will not, definitely not. And this is my third patient. Again, clinically it showed somewhat similar picture, but now you can see why doing an OCT is important in diabetic patients. Also, it's a very important patient education tool. You can show this to your patients and tell them about the seriousness of the condition that they are having. And because of this bad conditions, you can very well explain and justify the amount of injections that you're going to give to your patient. Now, this is a very important thing which all residents and all clinicians should definitely know. So there's an edema. I went for an anti-VEGF injection. I gave the injection. After 3 weeks or 4 weeks, the edema goes down. However, the vision did not improve. Now, how will you justify this? Why didn't the vision improve? The patient will ask, Doc Saab, the edema is not there. So why didn't my vision improve? Now you need to know, see all the layers from this part. They are well defined. But as soon as you reach the part where there was edema, there's somewhat a disorganization. Now this is called as drill, the disorganized retinal inner layers. See, the layers are somewhat distinctive here, very distinctive here. But there must have been some edema which is now resolved, and you cannot differentiate or distinguish the layers. Because of this drill component, the visual acuity gets affected. And also those three lines which I was emphasizing on initially. You see the external limiting membrane, the ellipsoid zone. They are coming at a very fine way, but then they get disrupted. There is no EZ over here. Since there's no EZ and this is the perifoveal region, the vision will again get affected. And you need to tell this to your patient that your vision will be compromised. It can never be as it was before because this is there. And once the patient sees it, that something is happening. No, I know now this is there. He gets satisfied. But you need to tell him, you need to educate him. So after such cases, you also have these type of cases in your OPDs, which are very bad. Now, when you do an OCT through these two, again, they show very varied pathology. But when you do a clinical photography or the fundus photography, there is some difference, but not huge difference that involves your central part of the retina or the macular region. Now, this patient will somewhat have better vision as compared to this patient. Okay. And why is it? Because when you see,
अच्छा ठीक
excuse me,
आ जाओ
could
चलो
you
हम लोग
please
चलते हैं अपन चलो
mute your
आ जाओ
mic,
बेटा चलो
sir?
बाबू आओ
Dr.
मम्मी
Govind,
बुला रही है, चलो आ जाओ चलो घर चलेंगे आप अच्छा यहाँ रिमोट है चलो
yeah, okay, so I did it for him. Yeah, sorry. So as I was saying, this patient at the above would have somewhat better vision as compared to the patient below. Now, why do I say that? I say just on the basis of this ellipsoid zone line. You can see it is somewhat patent over here, but it's not in this image. Though you cannot very clearly see over here, but yes, it's not that much patent. Also, in the either of the cases, I wouldn't suggest straight away to go for a surgical option because you can very clearly note the health of the retinal tissue. It's all skytic over here. It's missing. And there's a lamellar defect, huge lamellar defect over here. And over here, similarly, because of this tractional band, this white line, there's again a huge traction, schisis happening over here. And when you go for surgery of such cases, it's not a very easy surgery to remove this traction. And you might end up removing the retinal tissue as well. Thus, very well, you may harm the patient more than he is actually. So, after coming on to this, you also see cases of vein occlusion. Since you guys now know what are the layers and where you can see everything, this fluid is something which everyone is able to catch. Again, you will just see roughly that yes, this is the fundus image, and this is the OCT scan which has lots of fluid. I go for an injection, and this was the site. You don't need to stop here. You don't have to stop here. Again, emphasis on studying all the layers. So when you see this image, the above image, you see all the layers are perfectly fine, somewhat till here. After that, what happens? You see the ellipsoid zone starts breaking. Also, there is some scar involving the retinal pigment epithelium. And there's again a disruption over here of ellipsoid zone. So even after injection, the edema would go away, but these won't. This will stay. And this will affect the vision very markedly once that edema subsides. Similarly, if you see the below picture, again you can see a similar finding. So these are two different patients, the OCT of two different patients. And there's a lot of IRF, SRF, subretinal and intraretinal fluid. And again, you see, this is the external limiting membrane, the ellipsoid zone, the RP groups. The ellipsoid zone is patent till here, but after that it disappears. There's no more ellipsoid zone in this entire area. And this is subfoveal. So once that edema goes down, even the retinal tissue gains somewhat, the vascularity and the contour returns. But since the ellipsoid zone is not, the vision won't improve much. And you need to again show this to your patient so that you can justify why didn't the vision improve. Now, the middle limiting membrane, which I mentioned earlier, which is mentioned very clearly in the American literature. So this is a patient of non-ischemic CRVO that turned up in the OPD, and we did a scan. At that time, I wasn't aware of this middle limiting membrane sign. So I saw, no, everything looks pretty normal to me. There is nothing significant. So I'll just review you after 1 week, and I started him on some primary medication. That's it. Now, after 1 week, the patient came up with this. From non-ischemic component, it turned into an ischemic component. So then I studied about that, and this is that prominent middle limiting membrane sign. So if you see such a case, always be warranted that something is going to happen which is related to occlusion of the veins. And you may very well send the patient for a cardiology workup and you will find something. You will definitely find something. This happened because I missed this sign and the patient had an episode of MI, acute MI, in that 1 week's time. And after that, he turned up with us, the doctor, the cardiologist, he referred us because he said that the patient had suddenly lost visual acuity also. So you please have a look. And such a state happens. Now, this is again a very important component to predict the paracentral acute middle maculopathy or PAM. So you can see there are some hyper-reflective dots.
Dr. Vijay.
These are dots.
Dr.
Yes,
Vijay.
sir.
Yeah, just one thing I failed to understand in the last slide. Can you go back one slide?
Yeah.
The middle MLMN sign. What is exactly the sign? I think we all would like to know from you. What is exactly the sign? What is showing here?
So initially, when I was telling you about the anatomy, I told you about a green line, that there's a middle limiting membrane as well between the plexiform and nuclear layers. So now when you see this OCT, there is one very prominent white line in that area.
Yes.
This is that prominent middle limiting membrane sign. If you see such a sign in cases of non-ischemic CRVO, be warranted that this case is going to turn into an ischemic one. So basically, it is a prognostic marker.
So normally we don't see this line.
No, normally it's not there.
Okay. So can you compare this OCT with the normal OCT so that we can compare?
Yeah, I'll need to
it will be difficult,
back.
I know.
I'll need to go back just a second. Yeah.
Just the first photograph or this photograph.
Yeah. Yes, in this, you can see there's no prominent middle limiting membrane.
But the line is still BC, we can see here.
No, there's no prominent. It's not prominent.
Okay.
The emphasis is on prominence.
Okay.
Okay. So fine. In this image, it's not prominent. Now I'll show you the prominent image. Then you'll be able to understand it better. Yeah, now you can see it very prominently there. It kind of shines, you know. Like before, the line will definitely be there. So these all these membranes are not true membranes. So there is a complex there, definitely. Just that it's not shiny, it's not prominent. So once you see this in a case of non-ischemic CRVO, be warranted that it might very well get turned into an ischemic one.
Okay.
So this was mentioned in the American Academy part, and in our literature, it's nowhere mentioned. And while doing my post-graduation, I came across this. But at that time, I wasn't aware, so I totally ignored this middle limiting membrane because it was nowhere in our books. It was just in the retinal book of the American Academy. But while doing my fellowship, I saw such a case. And at that time, again, since I wasn't serious in my residency, so I again ignored it. But when the patient turned with such a thing, then, you know, my ears all got up and I was well warranted now. Now I'm very aware of this sign. So after this is again a very important prognostic marker. This hyper-reflective band. So when you see the normal retinal tissue and you see this white part, again it's shining, it's prominent. And similarly, here are spheres, hyper-reflective spheres. So this is known as paracentral acute middle maculopathy. Paracentral means which is not in the center, around it. And this is in the middle layers and involves in the macular area. When you see this, again be warranted that some sort of occlusion is bound to happen. These are all prognostic markers which you can catch on OCT, which we previously didn't know. We were never able to, you know, predict that this is going to happen. But now you can. And if you see such a sign, always send the patient for a cardiology workup or maybe a neurology workup as well. Because, you know, vein occlusions and arterial occlusions are not the primary diseases of the eye. They are just the manifestations of what's going on in your body. And if you are able to control your cardiology and your neurological component, then yes, you can very well avoid these diseases as well. Now, I'll show you again an image of this. So similarly, what we saw in the central vein occlusion comes the similar thing in a branch vein occlusion. The only part is it happens in the area that is occluded. So there's a large area which has, intraretinal edema, and the layers are all damaged. And you cannot appreciate the ellipsoid zone. Be mindful, this is a shadowing effect. This is not ellipsoid zone disruption. Whenever you see something going dark, which involves the entire longitudinal axis, that means this is a shadowing effect which is happening because of the fluid over here. That is not ellipsoid zone disruption. Okay, be mindful of that. Similarly, in the lower image, these are not ellipsoid zone disruptions because you can see the shadowing effect is going from over here to the choroidal area. So this is just a shadowing artifact. Now comes the arterial occlusions. So you saw in vein occlusion, there was huge edema. In arterial occlusions, the edema manifests itself in the form of these inner retinal hyperreflectivity. See how much they are shining, as if someone has put a bulb in there. So this is the inner retinal hyperreflectivity going on over here. Just a minute. I actually would like to, mute everyone. Yeah. Perfect. So this is the sign of arterial occlusion. Whenever you can very well come across a combined occlusion as well. The arterial component has such an image, which is inner reflectivity, inner retinal hyperreflectivity. Not reflectivity, but hyperreflectivity. It glows, and this is a sign of arterial occlusion. Now, once the cardiological or the neurological component of the patient has been treated, this reflectivity goes, but the vision doesn't improve. Why? Because as the chronicity develops, you see the entire reflectivity is gone, but all the layers have gone atrophic. And since all these layers have gone atrophic, the visual acuity doesn't improve much. Again, for patient education tool, this is a very good thing. You need to show him that why didn't your vision improve? It was just because all these layers have gone atrophic. Now, in my last slide, I want to show you one image again. Yeah. So now you can notice that there is a lot of fluid over here, some inner retinal fluid, but these layers are very reflective. They are hyper reflective. So this very well may be a case of a combined arterial occlusion, arterial and venous occlusion, which is happening in a branch only, not the central part. So this is the beauty of OCT imaging and studying it. By just having a look at the OCT part, you can very well distinguish a combined component. So after CRAO comes BRAO. Again, similar findings, what happening in the part of the artery which is involved. Now you see, again, this patient had PAM, which are the hyperreflective bands in the middle layers. And this turned into a BRAO in the acute phase. As the edema went away, the chronic phase entered, and now you can see this is the normal retina, but it has gone atrophic. And since it has gone atrophic, the visual acuity doesn't improve. Then a very common thing, CSR, especially in today's day, with lots of stress and anxiety, CSR is bound to happen to many youngsters. So now you can see, now I'll show you another important sign where people get confused during residency is difference between a neurosensory detachment and a pigment epithelial detachment. So as the name suggests, the above image shows very clearly a neurosensory detachment. Neurosensory means your neurosensory layers, the retinal layers. The fluid is below this, but above the RPE. The RPE doesn't get disturbed. So in this image, you can see that this is the part below the retina. However, the RPE is below this. And there's a acute angle over here. Okay, roughly around 45 degrees or something like that. However, in a pigment epithelial detachment, you can see the fluid is below this RPE. And this is the sign of differentiating a PED from a NSD, a pigment epithelial detachment from a neurosensory detachment. Note the angle here is somewhat a perpendicular one. In it was acute. In this, it is a perpendicular one. Now in CSR, you can also see many times this brush border pattern. This is nothing but your photoreceptors which are getting damaged and are getting shed away. Also, before in beginning of my presentation, I said that never make a diagnosis on OCT alone. Always do a clinical examination, see the fundus picture, if required, do an imaging, and then combine everything and make a diagnosis. Why? Had I had just this image, I could have thought very well, no, this is a case of retinal detachment. Because see the amount of NST, it's not even getting adjusted in one single scan. But when you see the fundus image, it doesn't look like a retinal detachment to me. And when you do an FFA, you can see the sign, which is a hallmark sign of CSR. Now you combine all these three and you make a definitive diagnosis of CSR and treat the patient on such lines. Next comes ARMD. Again, a very common condition seen in the setting of our country. So you see drusins. What are drusins? Drusins are nothing but deposits below this RPE. All the deposits will always be below this RPE. And there are bumps. These bumps are nothing but drusins. I specifically put this image here because just to show you this very bright, shiny layer, this is nothing but your epiretinal membrane. And because of this epiretinal membrane, there is some traction getting formed over here. And this leads to another sign, which is Eiffel. The Eiffel stands for ectopic inner foveal layers. This ectopic, they become ectopic. Normally, a foveal contour should have been there. That contour is no more there. And they are getting moved from their place. These are ectopic inner foveal layers. And with such an image, the patient is bound to have a very poor visual prognosis. So yeah, he can be taken up for a vitreoretinal surgery and removal of ERM can be warranted. But once you go for that surgery, still the patient's vision will be affected because of these sub-RPE bumps. So this is nothing but dry RMD where in the retina there's no fluid. Just these bumps are there. Now wet RMD has varied amounts of presentations. Varied. So they can be type 1 CNV or type 2 CNV, and there are many things. I will just show you broadly that whenever you see such an image, it is not dry AMD, it cannot be dry AMD. You see such a huge pigment epithelial detachment with a component of neurosensory detachment. And similarly, you see lot of fluid, a lot of activities going there. Some CNV or the choroidal neovascularization is starting over here. This image I put for a specific purpose. It was an old patient and the patient was injected for the removal of this fluid. Now the importance of patient education using OCT comes. You can show the patient that the fluid will go away after injection. However, this scar that is there, this CNV scar doesn't go. It might slightly regress, but it won't go away. So your visual acuity will only slightly improve, not much. Now, why do you want to inject? You want to inject because if this dry state is not achieved, the scar may very well get worsened more. So his visual acuity might also go down. But you need to be ethical as well. If the patient is somewhat, say, 88 or 90 years old, and his vision is somewhat, you say, around hand movements or even poorer, you don't need to inject such a patient because you won't gain much. The patient will spend his money also, and I don't think so it's ethical to just inject that patient. So again, you can show that why I am the one who's advising you that you don't need an injection. We'll just keep you under a follow-up with a conservative treatment. Now, again, as I said, there are varied observations. So in these images, I'll just show you the signs that are important. Now see, all the lines are coming very well. till here and even till here. But after that, you see all distinguishing lines have disappeared. So this patch, where all the layers have, they have lost their patency, this is nothing but a geographic atrophy patch. So whenever you see an area where all the distinguishing features have been destroyed, that shows an area which has undergone atrophy. Similarly, nowadays, a very important sign called the pre-choroidal cleft has starting coming up in the discussions because it is this cleft which is before the choroid, pre-choroidal cleft, after the RP, but before the choroid. This actually supports such large PEDs, and whenever you see this sign, chances of RP rip reduce. However, if this wasn't a cleft and there was, a cavern, a large cavern, that is a sign where RP rips are bound to happen. So you need to proceed cautiously. And you can also see a fibrovascular CNV formation. And this is a PCV case, which I'll show you in my next slide. So this is polypoidal choroidal vasculopathy or IPCV. I means idiopathy. So previously we used to do an ICGA to confirm this diagnosis. But now with the advent of the OCT biomarkers, doing an ICGA is not very important. You can make a diagnosis just by studying the OCT. So this is an image of the ICGA of this patient. And on the OCT, you see this double layer sign. The double layer sign means... Sorry, I need to stop every time to mute people. Yeah. Yeah, perfect. So this double layer sign, this is the basically differentiation of the RPE and the Brooks complex. The above area is the RP, the lower area is the Brooks. The complex that is there. See, there's such a small space and it gets separated. So it's kind of a PED only with multiple PEDs are there. And this is the double layer sign, which is the sign of this branching vascular network, which is seen on the ICGA. Similarly, there's another hallmark sign, like there's a hyper-reflective ring just under this PED and a tall, notched, peaked PED. These are the signs of, these are the biomarkers to catch IPCV on OCT. So you can see there's a notched and a peaked PED, but along with that, there's again this double layer sign over here. See the two layers which have irregular PEDs, and this is the sign of IPCV. And I don't know why, but in the setting of our northern states, this IPCV is pretty common here. Now, importance of this full thickness macular hole, the importance of OCT in this. So, as you say, I told in my previous slides about the vitreomacular traction component. So, in this stage 1A, you can see that there is some traction and it has started to pull the retina. On this lamellar macular hole, I'll come in my subsequent slide. In 1B, this traction gets even worse. So now those chytic spaces have started to arrive also. In stage 2, you see that it has opened up from here. A macular hole has formed, though the size is very less. Now comes the differentiation between stage 3 and 4, which you can't do on just by having a clinical look. You need an OCT for that. For stage 3, notice that the edges of these macular parts, the edges of the macular hole, they are somewhat tented. So it's like this. It's not like this, it's like this. There's a tractional part still. So because of that tractional part, there's a subretinal fluid ring over here. But in stage 4, like this is the image of stage 4, a PVD has been induced. And because of this PVD, there's no more tenting. That tenting goes away and this all gets flattened. So everything while doing a vitreoretinal surgery, we are always happy if there's a PVD already induced in the eye. So on an OCT, you can very well make a diagnosis of PVD, whether it's there or not. And that is the main difference between the stage 3 and stage 4 macular holes. Now, lamellar holes. Many residents, even clinicians get confused by looking clinically that whether this is a lamellar hole, whether this is a full thickness macular hole, how do we differentiate it, what's the significance? So always remember, when there is a lamellar defect, lamellar word means partial defect. So when there's a partial defect, you will see something like this. And this shining thing around the, this hole is nothing else but a epiretinal membrane. And whenever you see this epiretinal membrane, 9 out of 10 times you will have such an image on the OCT. And this is nothing but your lamellar macular hole. So when you see a lamellar macular hole, you can see this shiny white layer, which is the epiretinal membrane. Again, see those striations over here. This is not intraretinal fluid. Just because of traction, because of this epiretinal membrane, there is schisis happening here. There's a separation of the layers, middle layers, and this is macular schisis. And because of this contraction and pulling, there's a defect over here which is not coming full thickness. It's not all the way towards the outer layers, it's just involving your inner and maybe some middle layers. And this gives a lamellar macular defect. So these are the varied presentations in which the patient can present to you with a lamellar macular defect. Always do an OCT in a patient of macular hole or a suspected macular hole, and many a times you may miss out epiretinal membrane clinically, but on OCT you won't be able to miss it ever if you know how ERM looks like. This is my final case, a very interesting case, which again I saw in my OPD. So this was a young patient, 20s, and the patient used to love adventure sports. He was very adventurous patient, and he came up to me with a complaint of loss of visual, diminution of vision in his right eye past month, from 1 month. So on doing an examination, what I do on doing a clinical examination, the visual acuity didn't improve much, even with refraction, even with everything. And when you see this image, it relatively looks normal, like nothing much is going on over here. But when we do more imaging of the patient, you see that some abnormal activity is going on here. Still, I don't know what's happening. Why is it there? So I definitely need to go in more. So this is a case of a photic retinopathy. Why did I make this diagnosis? That the OCT aided me in that. And now comes the importance of catching that ellipsoid zone disruption. So you see this ellipsoid zone line is coming, and totally went away. This is just subfoveal area. So when such a disruption is there, you should always be warranted about the cause being a photic one. So I asked the patient, did you travel to a hilly area recently? Because the patient was very adventurous. And he said, yes, sir, I went for snowboarding. And the cause of his blindness was nothing else but a solar retinopathy or snow blindness that happened to him. And now you can show the patient, justify that visual loss. That you can see, yes, see, this is the area which is because of the harm you actually happened. So many times we are, in a habit of playing with those laser pointers, and we used to, put them in the eye and shine them in the eye just for playfulness. But don't do it. The guy in whose eye that is happening, he might very well land up with something like this. And this is something which does not get healed. Once the ellipsoid zone gets disrupted, it gets disrupted. So the patient was having a vision of 612 in his right eye, and it will remain like that. You just need to keep it under observation. So that was the beauty of OCT, that I was able to make a diagnosis which looked pretty normal to me on the fundus imaging. Okay. So what is my take home message? Always do a proper positioning. Avoid any sort of artifacts, be it in the form of vignetting or be it in the form of mirror. Never ever cross the zero delay line, because that will cause mirroring, and because of that you might very well make a false diagnosis, especially in high myopic cases. I personally prefer grayscale images, because in such grayscale images there's a very good appreciation of the different layers, which I don't tend to find it in the colored images. always remember the anatomy, because anatomy is the building block. Like we are taught in our MBBS days, in the first year, you always study anatomy first. In order to, correct your vehicle, you need to know what your vehicle is composed of, what are the parts, what are the connecting things. And if you know that, you don't need to mug it up, you need to understand that. And if you know that, you can very easily read such scans and make a beautiful diagnosis. Always remember the basics of OCT, and the final step is correlation of the all and interpret the scan. So thank you so much for your patient listening, and I hope many have gained something from my presentation today. Thank you.
So, Dr. Vijay, that was a very wonderful presentation. And after practicing for more than 20 years now, I really learned a lot from your presentation. So there were a few things which we ought to forget or ought to override or something like that. But see, that is the importance of these kind of CME, that you keep to know about the latest things which are happening, and also you start remembering those things which you have forgotten.
Definitely.
So thank you very much for your wonderful presentation. And I would request all the postgraduate students who are here, I think I can see many of them, there are more than 50 participants now, but kindly stick to your basics, understand each part of the retinal layers in a very, very precise manner, so that you can correlate your clinical examination with your OCT. So thank you very much, Dr. Vijay. Dr. Malay, as president of UPSOS and father of Abhijat, what would be your comments?
Yeah, I think it was a very nice presentation. He keeps teaching me a lot of OCT. And recently he has developed some tele-consultation facility also. But what I was thinking about, Dr. Abhijat, you have not mentioned comparing serial OCTs to get a comparative.
Yeah. So that is something which is known as progressional analysis. And progressional analysis comes in many machines, but not in all. It doesn't come with all the machines. It comes with towards the higher end machines, and it's a very beautiful thing. So again, like in patients with wet ARMD or with diabetic retinopathy, even with vein occlusions, the progressional analysis shows how the state was at the initial stage, then maybe after the 1 month of injection, or maybe after 2 months. And you can see all of that in a series. In just one screen, you can see all these scans. And that is what is known as progressional analysis. But unfortunately, it doesn't come with all the machines. But it's again a very wonderful thing and a very good patient education tool. So OCT, even OCT angiography, both of them are amazing patient education tools. Your clinical practice gets very easy once you explain the patient what's happening, and once he sees that, he becomes very compliant with the treatment.
Yeah, I think if we have any question from the audience.
One from my side. Can you measure the choroidal thickness accurately with the swept source OCT?
With any OCT, even spectral domain.
Okay.
Spectral domain with EDI, you can very well, measure the choroidal thickness. Not only choroidal thickness, you can also measure any sort of, swelling there.
Okay. Anybody else? Any question? And any comments from Dr. Sanjay Jain or Dr. Sandeep Mittal?
Dr. Shashank is also there.
Yeah, Dr. Shashank. Any suggestion?
So,
hello.
Yes, madam.
Yeah, excellent presentation, and it was very, very enlightening for all of us. Not only the residents, a lot of things. Abhijat cleared a lot of things about OCT, especially the ellipsoid zone and the inner outer zones of our photoreceptors. That was actually good learning for us also. And I would just request Abhijat that if he could repeat the CSR slide. Somehow I missed seeing the CSR. Just 1 minute in short, if you could just let us know about the CSR slides. Rest of the...
Okay, CSR. Yeah. I'll do that. No issues.
Yeah, CSR slide. Just in brief about it, because I somehow missed. But it was excellent. Congratulations, Abhijat.
Thank you, ma'am. Thank you, ma'am. Thank you for your support.
In a very simplified manner. No, that's wonderful.
So I'll just show you
And I
my
would like,
CSRs.
and I would like to congratulate everybody, Dr. Abhishek and sir also, for making this up for our residents, for clearing it, because actually OCT is something which is a gold standard nowadays, non-invasive. So it helps us in coming to the diagnosis, but the nitty-gritty details of it, we got to know today. Thank you, Dr. Abhishek, for
Thank you.
facilitating and coordinating. Ji, Doctor sir.
So in this side, what I initially told everyone was the importance of understanding the difference between neurosensory detachment and a pigment epithelial detachment. So neurosensory means there is a detachment of the neurosensory layers. The fluid is below the retina or above the RP, and there's a formation of an acute angle. However, in the PED or the pigment epithelial detachment, the fluid is below the RP. The angle over here is a perpendicular one. Right? Now, in cases of CR, also now since we all can appreciate layers much better, I showed it previously, but now I would like to show. You see some sort of PED formation over here, which is at a very early stage. So yes, this patient might develop a bad PED in future also. Now there is a photo pattern also, which shows that these photoreceptors are sharing. Not necessarily seen always, but yes, it can be seen in cases of CSR. Another thing which I highlighted here was never ever make a diagnosis solely on the basis of OCT. Always use your clinical acumen, your clinical examination, do the required imaging, do the OCT, and then make a diagnosis. Why do I say so? Because had I had this image only, I would very well have called it a retinal detachment, because you see this entire scan is not able to adjust the amount of NSD that is there. Now, when I did the fundus photography and even the FFA, you can see a well circumscribed area, and this nowhere looks near a retinal detachment, and you can see this very hallmark sign. And when I combine all these three, then I reach my diagnosis of CSCR.
Yeah, thank you so much. Thank you so much for once again repeating and clarifying whatever doubt we had.
Most welcome.
So I think he has told me that he will make a presentation out of it and upload it on YouTube for your future reference.
Yeah. So a Zoom recording of this entire session has been made, and I will be uploading it on my YouTube channel, and I will be sharing the link with everyone. So if anyone has missed it, they can also see it again.
So Dr. Abhishek, I think we have done a beginning. It's a beginning sort of thing for a CME series on the platform of UPSOS in association with through the ICT, and we will be definitely doing some more activity in the coming times.
So yeah, it was a pleasure, and I would also like to thank the entire UPSOS executive team for giving my WhatsApp group, the budding ophthalmologist, a platform so that we can do this at a a larger scale. And definitely, we will also look forward to conduct such things in the future.
With this, I think
so
we can call off the meeting.
Yeah.
Thank you, everyone.
Thank you, everyone. And for any queries, you may very well put it on the group as well.